Hello, and welcome to the special National MS Education and Awareness Month conference hosted by MS Focus, the Multiple Sclerosis Foundation, made possible with support from Genentech, Bristol Myers Squibb, Sanofi Genzyme, Biogen, EMD Serono, Novartis, and Beatrice. This presentation has additional support from Ocrevus. I'm your host, Chris Hudspeth, MS Focus Radio Manager, and today we're joined by Dr. Tyler Brown, who will be speaking with us about positive self-image for the disabled and chronically ill. After the presentation, we'll open it up to your questions and comments. Now, I'm delighted to introduce our speaker, Tyler Brown, Psych.D, joined Shepherd Center in August 2020 as a rehabilitation psychologist. Dr. Brown earned his MS in psychology at Lander University in Greenwood, South Carolina, and MS in psychology at Augusta State University before continuing his graduate education and earning an MS in clinical medical psychology and a Psych.D in clinical psychology at Mercer University in Atlanta, Georgia. He completed his clinical internship at Wichita State Counseling Center and Kansas University School of Medicine, Wichita, as part of the Wichita Collaborative Psychology Internship Program. Dr. Brown completed his postdoctoral fellowship at MedStar National Rehabilitation Hospital in Washington, D.C., and he's also an adjunct professor at Mercer University and has a passion for providing evidence-based treatment to individuals and their families dealing with a variety of complex medical conditions, including SCI, ABI, MS, chronic pain, and amputation. We're pleased to have him join us to present this important topic about positive self-image. Dr. Brown, thank you for being with us, and I'll turn it over to you.
All right, thank you very much.
All right, and we'll get the screen sharing going here.
I just want to say good afternoon, everyone. I hope everyone's having a good day so far. So like Chris said, I'm here today to talk to you a little bit about positive self-image, particularly as it relates to people who might be dealing with disabilities or any sort of chronic illness. I know this is an MS focus group. I think one of the good things that we'll discuss about the research today is that a lot of the same issues come up regardless of what the actual diagnosis may be. So this can be applicable to a very broad range of individuals. All right, next slide. So one thing we often have to talk about is disclosures, and the good news, to keep it short, is I have no disclosures to report. Next slide. So today I just want to discuss briefly where our direction is or some of the learning objectives that we'll be talking about, and then we'll just jump straight into it. So the first thing I want to be able to accomplish today is to be able to define self-image in a very broad sense for what that means for everyone, regardless if you have a disability or you don't. Next, I want to discuss a little bit about the concept of resiliency and how that relates a little bit to self-image and how resiliency looks after an injury or disability or diagnosis. Then I want to talk about some different frameworks for how, as researchers and psychologists, we view that, and we view how people make transitions from life pre-disability to post-disability, including different coping frameworks. Then I'd like to talk about some of the characteristics that are associated with people making that successful transition. Then I'm going to jump a little bit into disability identity. Disability identity is a very specific concept. So what is it like for people to integrate their illness or their diagnosis into their self-image in a positive and meaningful way? Then I want to discuss a little bit about positive psychology, which is a more recent movement in psychology, which is put very simply, and you'll hear me say this again, it's about focusing on what's right and not just what's wrong. So talking about some of the assets and strengths that a person has and how to be able to utilize those strengths or assets in a way that allows you to achieve that healthy coping style. And then finally, I just want to talk a little bit and review some opportunities for treatment and support. So not only like what are some things that you can do and what are some frameworks we can work from, but how can you, after this talk is over, go out and achieve some of those things for yourself. Okay, next slide. So first off, just talking about what is self-image, and I really like this definition that I found from the Cleveland Clinic. So they define self-image as our personal view or a mental picture or representation that we have of ourselves. In some ways, you can think of it like our internal dictionary. So it describes the characteristics of ourselves that we tend to focus on. These are often the adjectives we use to describe ourselves, such as intelligent, beautiful, ugly, talented, selfish, and kind. And these characteristics form that overall collective representation of how we see ourselves. And it's really just how we view our assets or strengths and our liabilities or weakness, and in terms of the way we see them. And I feel like the picture I chose here is a great way to identify self-image, right? We can see ourselves in a lot of different ways. And as you'll hear me say several times throughout this talk, the objectivity of that doesn't really matter. The way we feel about ourselves and the way we relate to ourselves matter more than what's maybe the reality of the situation. And you could maybe think of some prominent sports figures and people that maybe were able to achieve a lot more than what life or society told them that they could achieve based on the fact that they had a really positive self-image. Okay, next slide. So let's talk a little bit about where self-image comes from. Self-image is ultimately a product of learning. We grow up in an environment, and our interactions with people in the environment and with ourselves ultimately are going to help shape that self-image. So our self-image comes from really everywhere. Early on, it's often the people who are closest to us, like our parents, caregivers, peers, siblings, family. As we move out into the world, that becomes our bosses, our coworkers, teachers, social media, advertising, and anything that we interact with in our environment is going to help shape our self-image or how we view ourselves. And in some ways, self-image represents a constant appraisal or an assessment of ourselves, usually as a comparative analysis to other things. How do I look today? What's my appearance like? What does that compare to what maybe my ideal self is? What does that compare to how society's ideal self is? How am I doing performance-wise? Am I good at my job? Am I bad at my job? Am I succeeding in life? Am I not succeeding in life? And how important am I? You know, am I loved? Am I respected? Do people notice me? Do my colleagues respect me? So basically how we review ourselves in our relationships. The big takeaway is that we really want to develop loving and accepting relationships with others and with ourselves. If we want to develop a sense of positive self-image, we want stability, we want love and respect. Next slide. So how we interpret our self-image is also a really important thing to discuss. In general, people with positive self-image can recognize what assets and strengths they have, but they also have a realistic appraisal of what their liabilities and weaknesses are. So one thing I want to point out here is that having a positive self-image isn't seeing the world through rose-colored lenses, right? If we were to think of someone who had saw nothing but their strengths and their assets, but weren't recognizing liabilities and weaknesses, we might call that person arrogant or self-centered, or we might subscribe some negative connotation to them. So positive self-image isn't about seeing the world through rose-colored lenses. It's about recognizing what's going right in your life or what's good about your life and good about yourself, but while also appreciating the weaknesses and liabilities we have. Conversely, negative self-image, often we tend to really focus on our faults and failures. It's kind of like holding a magnifying glass up to whatever we think is wrong with ourselves. And ultimately, that leads to a distorted view of our failures or imperfections and the role they play in our lives. So if I focus on a weakness that I might have, I might misattribute how much of an impact that actually has in my life. And then I'm probably also likely to discount those strengths and assets because those don't matter anymore, because these negative things, these weaknesses are so strong that it doesn't really matter. These strengths and things aren't going to see me through this. And another important thing to mention is that self-image is dynamic and changing. Not only do I mean that as a product across the lifespan, meaning our self-image change as we have life experiences, it can change from moment to moment. So maybe my self-image as a professional might be skewed positive or negative based on my interactions with coworkers. So if you've ever had a bad boss who's very critical, you might have a negative self-image of yourself as a professional, but when you go home, if you think that you're a good spouse, you can have a positive self-image of yourself as a spouse. So our self-image is dynamic and changing at all times. Next slide. So a couple of things I might ask you just to think about as we're going through these slides and this discussion in terms of yourselves. Where was your self-image before your disability or illness? Before maybe everything that happened started, how are you feeling about yourself at that time? Because that could be really important here. Was it that you had really good positive self-image, and now that you feel like you have more of a negative self-image after this impactful thing has happened in your life? Did you have negative self-image beforehand, and now you find yourself struggling the same or more with that concept? And then the next thing I would ask you to think about is what changed about your self-image after your disability or diagnosis. So what types of things did you focus on after your diagnosis, or what types of things about your self-image did you recognize maybe immediately after compared to now? And then I'd have you think a little bit about what influences your self-image today and how that's maybe changed throughout your journey. And more specifically, you might think about what biases you might have about, or stigma you might have about disability, and how that interacts with your self-image of yourself. How does your family's reaction to your diagnosis, your disability, how has that framed your self-image? Society's views of disability, how maybe has that interfered with or influenced your self-image? And maybe even what I mentioned a second ago, the location of the situation. Does your self-image change depending on the environment you're in? So does it change when you're at a doctor's office versus when you're at home versus when you're at work versus when you're in the grocery store? Okay. So briefly, I want to talk a little bit about resiliency, just to recognize that there are differences in our environment and in our lives that can influence our general adjustment to a diagnosis or disability. Just quickly to define resiliency, it's often described as a capacity to recover quickly from difficulties. You know, it's a flexibility to be able to adjust to the environment and to be able to bounce back. A less psychological definition is the ability of a substance or object to spring back into shape, or elasticity. Even though that doesn't deal with the psychological definition, I really like that definition too. I like that image of being able to bounce back or to go back or retain the properties we once had if things feel like they're getting out of shape. So some of the things that really influence resiliency that we've in psychology have studied extensively. It's one of the big things that we like to look at, especially as it relates to health complications. We generally divide them into the protective factors and the risk factors, and these are usually inverses of each other. So environmental protective factors are things like community resources. This can be affected by like SES, or you in a high SES community, low SES community. It could be affected by like geographic region. So people in rural places have less resources than people in urban environments or cities. Access to safe housing and finances is often a really major barrier, and it's a big thing that we often look at in terms of like access to healthcare. So depending on where you're at on that continuum of protective factor to risk factor can really influence how you're able to bounce back or cope. Social interpersonal characteristics, things like having a stable family environment, employment, social support and friends are key. And obviously the risk factors there again are the inverse. So not having family support, being unemployed, and having limited or no social support can make things very difficult. And then the psychological and physical aspects of it as well. So having a healthy sense of self-esteem for the purpose of this talk can be used interchangeably with self-image. Um, Physical health relative to everything else that might be going on. So the more health complications you have can influence your resiliency, as well as general problem solving skills. So what's your ability to navigate your environment, to be able to locate and find resources, to advocate for yourself, versus things like anxiety and stress. And I like to add a caveat there. Anxiety and stress are normal, and they're a normal part of our lives. I think what people often struggle with more is when they have anxiety and stress and they don't know how to cope with that anxiety and stress. And then they start to feel that sense of loss of control. Having compromised physical health, and then having a poor communication skills. Okay, next slide. So one thing that I would like to discuss, and you'll see this name come up a lot. So Beatrice Wright is a psychologist who is prolific in rehabilitation psychology, and her work was really big throughout the 70s and 80s. But a lot of what she did was so forward thinking that it's still a cornerstone for everything that we do today. So you'll hear her name a lot, and if you're interested in doing some research or some things beyond this talk on your own, Beatrice Wright's a great person to look into and research. So she proposed pretty early on in the 80s that disability happens on more or less of a continuum of a positive response to a negative response. And she labeled the positive response as coping and the negative response as succumbing, as it relates to disability onset. At first, when people first have an injury or a diagnosis, or they start to have a disability from their illness, there tends to be more of a rapid shift from positive to negative, and one day can be positive, one day can be negative. But as time goes on, people tend to gravitate more to one side. Not to say that things can't still be flexible, but they become more inflexible as time goes on. People tend to find themselves leaning to one side or the other. Another important thing to note, and you'll hear me talk about this a lot today, is this framework serves as both an insider model, so PWDs being persons with disability. So this applies not only to you as the individual, but this thing doesn't happen to you in isolation. It affects your family and your friends and your social lives. So a lot of the things we'll talk about not only apply to you, but they apply to the outsiders as well, the family and the caregivers, the professionals you interact with, your coworkers, really everyone. So when we talk about that continuum, what the research indicates is that having a succumbing framework often leads to more a focus on more negative aspects of the disability and more of a focus on the losses associated with disability. So people might tend to focus more on what can no longer be done versus what could be learned or relearned or what hasn't been lost. And kind of the inverse of that, on the positive side of things, people that develop more of a coping framework leads to a focus on intrinsic values and retained or potential assets. So really those parts of our personality that don't change. Even after we face adversity or hardship, those are things about ourselves that are very hard to change. All right, next slide. So qualities of coping and succumbing. In general, coping would be representative of people who try to be active and independent, so active problem solvers. They try to gain independence where they can. People that are participating, engaging not only in their lives and their social activities, but trying to be actively involved in their management of their health care, trying to make healthcare decisions, trying to make informed decisions. No de-evaluation of self, skills, or limits. So not being overly critical of yourself or what your limitations are or what your skills or abilities are. They tend to be people that work or alter to eliminate the physical and social barriers they have. So that kind of goes back to that active coping style. The negative aspects of their daily life are often deemed manageable. So it's not that they have, again, rose-colored lenses of like, oh, this is so great that this is happening, but it's more of like, this sucks, but I can deal with it. And I think I can find a way to manage this. Understanding and accepting those limitations, being able to seek helpful medical procedures, assistive devices, or helpers. Again, a very active or proactive style of coping, and promoting meaning and life satisfaction in themselves. So they generally find some sort of meaning or purpose that still gives their life a lot of fulfillment. The opposite of that, succumbing, often have more of a passive or a dependent personality. They often tend to focus a lot on their shortcomings or the drawbacks or the things that can no longer be accomplished. They often assess progress based on non-disabled standards. So if I'm not progressing at this the way that I could have beforehand, then I'm failing. They tend to de-emphasize areas where they can still participate and focus mainly on the loss. There's generally more of a view of themselves as a passive agent in their lives or as a victim instead of someone who can participate in their lives and get involved and advocate for themselves. They often maybe resign themselves to their condition, or total opposite. They might act if their disability doesn't exist at all. They try to ignore it, particularly when they might not have any flare up, or if symptoms have lessened. They might try to do what we call pass as a non-disabled person. This might lead to pity with self or others with disabilities. So not only a negative view of self, but a negative view of other people with disabilities that arises from stigma. And they might focus a lot more on prevention or a cure instead of adapting or adjusting to their current environment to make their life more satisfying now. It's more of a hope of like, I can't wait for this cure to happen. I can't wait to get back to the way I was. Okay, next slide. And so Dunn is another prolific rehabilitation psychologist that you'll hear me talk about a little bit today. And his work has been absolutely phenomenal. And what he did is he looks a lot at some of the differences between people that adopt that coping framework versus that succumbing framework. And some of the things that he found is people can often paint a more positive picture, or they can shift their focus or perception in such a way that they notice the negative less. So things like social comparisons, which we all do. A negative social comparison would be like, well, I can't do what that person does, right? And so that's going to make me feel bad about myself. A positive social comparison that he found in his research might be, well, I've got it bad, but what about my peer over here? And this is something I see a lot when I work with inpatient spinal cord injury, when people have an opportunity to be around a lot of peers that have similar issues. I'll see this as a central theme. People will say, well, yeah, I've got it really bad, but Joe over here has got a higher level of injury and he can do less than me. So, I don't feel as bad about my situation. He found that people often find some sort of side benefits. So occupation changes. Oh, I hated my old job, and since my injury, I went back to school, and now I like my new job a lot more. Family re-engagement. Well, before my injury, or before my disability, I was a workaholic, and now I've spent a lot more time with family, and boy, I really miss that, and I appreciate how much of that I didn't have. Or in general, life priority shifts, where people will often say to me things like, well, yeah, like I thought that was important. I thought that having the new house or the boat or the car was important, but now I don't see that anymore. I've reconnected to these other values in my life. Forgetting negative aspects. So things like, I can do what I did before, I just need more time, which is a good reframe. Or I'm glad I can still do X or go to X. I'm glad I can still go to my children's baseball games, or I'm glad I can still do this. Imagining worse situations. So thinking, well, things really suck right now, but I'm glad to be alive, and this is a second chance at life. And then the final one are just general positive reframes. So kind of relating back to everything we've talked about so far. A lot of good has come from this, or I found God through this, and I often see a lot of spiritual awakenings in the people that I work with. People might say that it's given me some sort of sense of life purpose, or it's redefined life meaning for me. And on the high end of the spectrum of disability identity, sometimes people will even say, hey, it makes me different or special, and I actually like that. And I put this image up here. Sorry, can you go back real quick? To highlight that issue of perspective. And I'm sure we've all seen these Gestalt images, but do you see two faces or a vase? And the answer is both is there. We can actually choose which one that we look on. And even though we initially might see one over the other, if we look hard enough, we can eventually see the other. Okay? All right, next slide. So now I want to move a little bit more into disability identity. It's a very important thing that's been researched, and we know that people that develop a higher, more positive sense of disability identity fare much better than people who either tend to ignore their disability or they have a negative disability identity. So this is positive disability identity just refers to having a favorable or beneficial self-beliefs regarding your own disability, as well as having positive ties to members of the disability community. And this can be described on a continuum. We don't have to go through each of these steps for the sake of time, but it ranges anywhere from being unaware or having a rare recognition of our disability, especially for people that might be able to sort of pass as non-disabled, all the way up to people that have an awareness and involvement in their community, all the way up to the people that might be people with disabilities who are also advocates for people with disabilities, or who get very involved in legislation or nonprofits, peer support, those types of things. Okay. Gill, who's a researcher, proposed an identity development model that's similar to other identity development models. It's a 4-stage. He says that when people start to develop an early sense of positive disability identity, it starts with the stage that he called belongingness, which is just a recognition that I have a disability, but it's within the context of this larger society, but I still have rights and roles like everyone else does. And that's in converse to a negative identity development where people might feel ashamed of their disability, or they feel like they aren't entitled to the same rights, or maybe they feel less than. After belongingness, Gill proposed was coming home. So as people start to become more aware of their disability identity, they want to become more involved with that community. So they get more involved with people that might have either the same illness or injury, or just the disability community at large, and start to recognize the shared experiences that other people with disabilities have. Then he said is coming together, which is a bit of an integration and appreciation for the similarities and differences that we have with that culture at large, and the recognition of our participation in disabled culture and the larger culture. Last, he said, is coming out, which is a positive integration of all of those features toward a positive or ideal self-identity. So one that is confident and clear, and a strong positive identity with the disability of saying, I am a person with a disability, I'm equal to everyone else, and it's not something that I hide from anyone. Okay. Another thing we'll go over real quick that's related to self-image or personal narratives. And the reason I bring this up is that these are our actual personal stories that we tell ourselves. We all have a personal narrative. Like right now, if I told you to, explain your life to me or give me your 60-second biography, this would be whatever you would say in that. So it's how you frame your life experiences, your worldviews, your personality, your self-image, all of that. So the important thing about this is when people give us their personal narratives, it gives us a personal view into their lives, how they feel that they're doing, and where they feel like their place is in the world. Again, I want to highlight that the relative truthfulness of our stories matters less than what we actually tell ourselves, because what we tell ourselves is happening is what's driving our behavior, or our perceptions of the world around us. So Dunn and Burklaw reviewed personal narratives of people with disabilities, and they found some common themes among them. Next slide. So communal attachment, which is a desire to affiliate with other people with disabilities. Affirmation of disabilities. So the private thoughts and feelings of inclusion in larger society, including the same rights as others. So again, kind of that self-advocacy piece of just because I have a disability doesn't mean I'm any less than you, and I have the same rights that you do. And then I can be affirming of my disability, and I can advocate for myself. Self-worth, so seeing yourself as someone who has value, particularly with people with disabilities, seeing yourself as having equal value to someone who is non-disabled. Having a sense of pride, so being proud of your own personal identity while recognizing having some sort of devalued quality, so that even though society might have a devalued quality of you, you can still have a positive sense of pride for yourself. Discrimination, so having an awareness of the self and that other people with disabilities are targets of presidential behavior, and recognizing where those lines are and recognizing what that means or how that influences your life. And then the final one that's really important, personal meaning. So what significance, how do you make sense of what's happening to you in life, and identifying the benefits that are often associated with disability. Okay, next slide. So I told you we would mention Beatrice Wright again. I won't go into all of these, but this is something I would encourage, especially if we have any providers. If you're not aware of these, this applies for family members. This applies really for anybody. I think Dr. Wright's values-laden beliefs and principles are very important. She originally developed them in the 70s. This is the second edition from 1981, but they're so important that in rehabilitation psychology, when we go for our board certifications, we still are judged by these today. And that's what I meant earlier when I said she was way ahead of her time. So there are 20 principles, and I'm only going to go over about half of them. But for the sake of time, I do encourage you, if you're interested, to look at the other ones, because I think they're great. So the first principle she came up with is that every individual needs respect and encouragement. Number two, severity of disability can be increased or diminished by the environment. I think people with disabilities early on will often see their disability only in the individual framework of, well, I have this impairment and that means less about me. And we don't focus on how the environment is often set up not to allow for people with disabilities to navigate the world very easily, right? And that has nothing to do with you having a disability. That has to do with our faults as society not doing a better job of being accommodating. Principle three, so issues of coping and adjustment cannot be validly considered without examination of the environment. So again, people's adjustment and coping isn't all about them. It's not their problem. There's a problem with society at large, or there's a problems that go on in the environment that contributes to whatever problems the person's having. And we have to examine all of that in order to have a fair appraisal of what's going on in the person's life. Number four, and then we'll get into this with positive psychology, assets of a person must be considered. We can't just look at what's going on wrong in a person's life, or looking at just what needs to be fixed or what we feel is broken. We have to hone in on what a person's strengths and abilities are as well. And we have to be able to bolster those in such a way to help the person. Principle five, so significance of disability is affected by a person's belief about the self and the situation. So disability is a subjective experience as well as an objective experience, and how a person frames their disability or how they feel about themselves is important as objectively what they're going through. And this can lead to things like resentment or feelings of inferiority or guilt or loneliness or feeling like a burden or general love and acceptance, and worries about the future and where things are going to go from here. Next slide. Principle six, active participation of the person in all roles as fully as possible. some of you might be able to relate to this one a little bit. I actually had a client recently tell me that she went in with her husband to see a professional, and the professional talked to her husband the whole time. Like, that's unacceptable. The individual is the person who's going through it. Like, you have to talk to both people because you're treating the whole unit. You're not treating just the individual. So it's important to talk and address everyone. And a person with a disability deserves to be as much a part of that, those decisions and that appraisal and that conversation as much as anyone else. Speaking to that, Principle 7, so the person needs to be seen as part of a larger group. So understanding the family dynamics, understanding the social dynamics, the environmental dynamics that play into that person's life and the framework. Recognizing Principle 8, recognizing the idiosyncratic variables of the individual. So realizing that two people with the same disability aren't going to be the same, and that there are individual variables in there, and we have to appreciate each individual's response. 12, self-help organizations are important allies. I'm a huge advocate for like the nonprofit associations, social support group, resource management, and all of that. And I always encourage the people I'm working with to not only seek the professional help in terms of individual counseling, but to me, peer support is integral. 15, involvement of people with disabilities in general life of the community. So we can't make decisions for people with disabilities without including people with disabilities. Because one, it's not fair, and two, inevitably we're going to get something wrong because there's something that we're not going to see because people with disabilities have that unique framework of their experience. That relates to Principle 16. So people with disabilities are entitled to participate and contribute in the community. And then Principle 19 is people with disabilities should be called to serve as co-planners, co-evaluators, and consultants on any and all projects that involve their well-being. Okay. So now I want to talk a little bit about, wrap this up into positive psychology and the movement in working with people with disabilities. Positive psychology is a newer movement, but really it reflects a lot of what Dr. Wright was trying to highlight so well. So positive psychology, like I mentioned earlier, is more of an emphasis on what a person's strengths and assets are in order to build or harness those for coping. This is in lieu of traditional models of psychopathology, which are more of a medical model, which saying that there's something wrong, right? So you're depressed, so let's fix that depression, or you're this, let's fix that. So it's more of a focus on deficits or what's wrong, and not as much of a focus on what's right. So you can see that this lines up nicely with what we've discussed so far. We can't really help someone if we're only focused on everything that's wrong in their lives, because there's not a single person that doesn't have a strength or an asset that can be utilized to help improve their situation. So positive psychology focuses a lot on the roles of positive emotion, attitudes, actions, and traits, as well as maintaining a general psychological and physical health and contributing to a person's overall sense of fulfillment in their life. Okay, next slide. So again, for the sake of time, I'm not going to go over each of these individually, but just take a second to look at this chart. These are some virtues that some researchers came up with that are character strengths. And one thing I've noticed when I work with people with disabilities that maybe have a lower sense of self-worth or lower self-esteem is that they often lose sight of what some of their assets are. And looking at this right now, I imagine everyone could maybe identify one or two strengths or assets that they have. Well, these are like your superpowers. These are the things that you can draw upon that can help you. And I can tell you right now, I have never met or worked with a single person that didn't have some wonderful assets or wonderful strengths that they couldn't draw upon. Okay. Next slide. So I want to jump into the next concept as it relates to positive psychology, which is what we call, and has been coined, living the good life with disability. And this has come a lot out of what Dunn's work has done. So living the good life as defined by Dunn, is one that is personally satisfying, fulfilling, and meaningful, which means it is an individual experience. So it's unique to each of us, and it's tied to our shared perspectives in the overall human experience. So how we derive meaning in our lives, or satisfaction in our lives, or fulfillment in our lives. This often leads to positive connections with other people. So loving people, being able to forgive wrongdoings, maintaining our relationships with other people, and just having general life skills in order to maintain and form relationships with others. A couple of concepts here that'll be important to understand or capitalizing. So this is when we're talking or discussing with other people and trying to build relationships, to remember that we need to respond with enthusiasm, sincere interest, or to be attentive listeners to generate positive emotions, right? So it's not always about us. Oftentimes we can get caught up in sharing our own stories, but building relationships with other people is reciprocal. So we need to remember that, and we need to be able to capitalize on that, as well as offering help to others. So random acts of kindness. Just because we have things going on in our lives doesn't mean that we can't do something nice for someone else. And boy, does that just not make us feel really good. And there's one quick story I want to share here. I remember one time years ago, I was in a McDonald's drive-through, and I pulled up to the first window where you pay, and the woman said, "Oh, you don't have to pay. The person in front of you paid for you." And I was like, "Wow, that's great!" Like I remember the rest of my day just being really good because of that small thing that person did for me. It was a stranger. I don't know who it was. And the next time a similar thing happened, I paid it forward for the person behind me, and so hopefully we got a nice chain going there. And think about how small of a thing that might have been, but to this day, it's something that I still remember. And that's the impact that had in my life. So no act of kindness is too small. Okay, next slide. It's also about our positive personal qualities. So expressing gratitude, that's associated with very high well-being and fosters better relationships. And I feel like when I'm sometimes working with people who are depressed or feeling bad about themselves, they tend to undermine what their gratitude or what their acts of kindness can do for other people. Like my family members have to do so much for me. It doesn't really matter that I thank them for what I'm doing, or buying them a small gift doesn't really matter. I've heard things like that a lot, but those things matter so much. And think about how you feel when people do that for you. It's a very powerful thing, and it's something that you can do to give back. A sense of humor is always a good thing to have that's been associated with positive coping. Not only does it magnify the positive emotions we feel, it also is a good way to reduce the amount of stress that we experience. Grit, which is defined as passion for achieving long-term goals and having the necessary perseverance to meet them. So just that drive, that goal, like nothing's going to stop me. I'm going to work through it. I'm going to keep it. And no matter what, I'm going to see that long-term goal through the end. Okay, next slide. So life regulation qualities. So what are our abilities to maintain our autonomy or to exercise self-control as we develop new interests or pursue new goals, or to have some effect on the lives of all of those around us. So this is everything as simple as fulfilling our ADLs and our everyday life experiences like chores and hygiene. Exercising is not only good for physical health, it's also great for emotional health, and it's great for building that sense of autonomy and control and positive self-image. Creature comforts are always important. So the expression, I don't know if anyone's a Park and Recs fan, but treat yourself. Engaging in our hobbies, our interests, a good meal every once in a while, relaxing, intimacy. Those are all those creature comforts that are important. And if we lose those, then there are going to be problems or issues. Generativity, so that sense of giving back. So this is that community involvement. So this could be being a mentor, being an advocate, being a member of a social support group, just reaching out to a friend, or if you have a friend who's going through a similar experience, reaching out to them. So just that sense of giving back to the community and contributing to the community. Next slide. This is something that I often will do when I'm working with clients or patients. That's called a values bullseye. So think about everything that we just discussed. If you want to think about it in terms of a bullseye, whether your values are in work and education, leisure, personal growth or health, or relationships, which are kind of the four big encompassing areas that we'll often talk about, think about how far away from the bullseye you are. If you put your X in the bullseye, that means that you're living that value 100% the way you want to. And oftentimes when people start to have low sense of self-worth, low self-image, anxiety, and depression, they find that their X's are much more to the outside of the circle than to the interior of the circle. Okay? Value change is another important part of positive psychology. And this is true not only in positive psychology, but new wave therapies like acceptance and commitment therapy. They're designed to be less about what is wrong and more about what's going right and reconnecting to your life. Remembering what matters and achieving that fulfillment in your life. So values aren't about what you want to get or achieve. Those are more of goals. Values are different than goals. So values are about how you want to behave or act on an ongoing basis, how you want to treat yourself, others, and the world around you. And they're directionless. So what I mean by that is, let's say a value might be to be a good parent. Well, there's not an endpoint to that, right? That's a value. A goal might be, I want to get to all my kids' baseball games. That's a goal. A value is, I want to be a good parent. The good news about values is, even though they can be taken from us initially, we can often reconnect with them. So maybe beforehand, being a good parent meant playing catch, and now you can't play catch anymore. We can still be a good parent by being there, by providing emotional support, by going to your children's activities. So that's the kind of shifts we're talking about in order to be able to reconnect with our value systems. Okay? So value assessment is about focusing and appreciating on the larger context. So kind of like that example I just gave about being a good parent. Appreciating values across different psychosocial environments. So our personalities, our skills, our interests, our competencies, and not just what our physical concerns are, which often people with disabilities get wrapped up in. You're still a valuable person. You're a person that still has value no matter what. You always have value, and you have as much value as anyone else. And that kind of relates to this next principle, which is containing spread effects. So remembering that disability is that person-environment relationship, and that the psychological and physical barriers are created by the environment. And so what we are in one environment, we aren't in another environment. So if there's one environment that we really struggle in, chances are there's other environments that we don't struggle in as much, or maybe even at all. And it's important to recognize that those negative aspects of ourselves, or those things that we're working on, don't have to spread through our entire lives. They don't have to take over our life. Okay? And kind of one of the big take home things I want to say here today is transforming the comparative status that we often have into asset values. So social comparison is completely normal. We all do it. We do it on a daily basis. We do it all the time. We compare ourselves to everything else. We compare ourselves to society's models of beauty or success or whatever it may be. And oftentimes for people with disabilities, they might either compare themselves to other people with disabilities, non-disabled people, or themselves before they were disabled. So those are very common features that we'll see. But that's often not very helpful, and it's not going to get you very far. What is helpful, and what we know, is to focus on the relative progress that you're making. Your effort matters. The things that you're trying to do to influence your life matters, and that hard work matters. And it doesn't matter if you're maybe not achieving that goal the way you wanted to achieve it, or you're not achieving it as fast as you wanted to achieve it in. That the progress that you're making matters. Okay. So just some big take-home messages. Again, self-image is a personal view, or that mental representation we have of ourselves. Positive self-image following disability is associated with positive disability identity. Active strategies to adjustment are superior to passive ones. Values, so what we do and what we believe in, or what gives our lives meaning, are often neglected, or at the very least disrupted, following disability, but they serve as very key elements to regaining a positive identity or regaining healthy adjustment. And finally, positive psychology offers an approach to assess what is right as opposed to what is wrong, in order to help people with disabilities find meaningful direction. Okay. Next slide. So finding help and next steps, a couple of things I would recommend is if you're struggling to always seek help, it's always good to have a frame of reference from someone else, whether that be friend, family member, or professional. I often encourage people often ask, well, how do I go about finding a therapist? Psychology Today, which is an online publication, has a very good classified system to be able to look up therapists, and it'll tell what their specialties are, you know, what kind of people they generally work with, and what types of therapies they do. So it's a good way to sort of pre-screen individuals, as well as calling your insurance company. If you call your insurance company, they'll often give you a list of providers in your area that they'll cover. I generally recommend that if you're going to seek psychotherapy, that you see someone who uses evidence-based treatments. Big ones that I'm interested in are cognitive behavioral therapy, acceptance and commitment therapy, and positive psychology. By no means is that an exhaustive list. Those are just a few of the ones that you might look for. Another thing that, depending on the area you're in, remember that rehabilitation psychology is a specialty field. So if you have had negative experiences with psychotherapy in the past, there are experts who are trained and specifically deal with people who are having issues related to rehabilitation, so physical disability, injuries, those types of things. Connecting to peer support or support groups, again, like I said earlier, I think is one of the most important things that people can do to be able to connect with others who can really resonate with what you're going through. And connecting to any sort of community or advocacy services, and getting involved and becoming a part of the disability community, I think is very beneficial. The last little story I'll share, and I'm sorry I'm running a little bit over here, is and I had a client who promised he was going to watch this, so he'll yell at me if I don't tell this story. But we were talking about it, and something that I'll often see is people want to suppress their disability identity. It's kind of like when we're a kid and we think that there's a monster under our bed in our closet. As long as we try to suppress that thing and we keep it out of our mind, it'll continue to be that monster. It'll continue to be that negative thing that's overtaking our lives and influencing our behaviors and making us afraid and fearful to live in our lives. When we can finally accept it and look under the bed or look in the closet is when we can finally find a way to move on and to be able to integrate that into our lives in a positive way. Okay, and then the last thing I'll say, if you have any questions or anything you want to follow up, please feel free to email me if you have anything, and if I can, I'll be willing to help you in any way that I can provide services. Okay. I just want to say thank you to Dr. Ben Thrower, who's a physician here who kind of hooked me up with this. Thank you to MS Focus, Debbie, for helping set all this up, and everyone else who helped today, who I met today. I want to say thank you to Dr. Kelsey Hewitt, who's my fiance, who helped me prepare for this presentation. She's a wonderful lady, and I'm very lucky. And I want to say thank you to all the wonderful people I work with. So kind of to sum up everything I've said today, when I'm working with individuals, clients, and patients that I work with, not only am I trying to influence your life, but you influence my life as well. And that kind of sums up what I said about having value. And I learn as much from the people that I work with, I think, as they learn from me. So I appreciate them, and I appreciate being a part of their lives as well. Okay.
All right. Thank you so much, Dr. Brown, for your presentation. It's fascinating, in fact, and goes pretty deep. I know you covered a lot of ground today, but certainly there's a lot more to what you said, and we thank you. Thank you for that. I presume some people have some questions for you, and we're ready to take questions now. If you do have a question or comment, please use the raise your hand feature in the app or send your questions to us via chat. And to raise your hand, click the screen to pull up the menu, select more. It's the icon with the three dots, and click raise your hand. I'm going to unmute you. Then a prompt will appear on your screen asking if you will allow me to do that, and just please select allow. So I'm going to start with some questions that are in the chat. One is, let's see. This is from Debbie Foreman. Would you
can I hop in there first, Chris?
Oh, sure, of course.
All right, thanks. Dr. Brown, I have two questions for you. First of all, can you speak briefly? You talked about the concept of passing. Can you speak briefly to how a person develops a disability identity when they either have intermittent disability, or they're not sure if their chronic illness symptoms rise to the level of what the community considers disability, sort of a disability imposter syndrome? How do you deal with that?
You know, I think that's a wonderful question, actually. So I think I don't think that it necessarily has to boil down to that you wear it on your sleeve at all times, as long as you're willing to have that integrated identity. And certainly there are going to be times where especially, and this is true, especially for MS, right? So when you have a disease that can be relapse remitting, there are going to be times when passing is a lot easier than others. And that might be different than a spinal cord injury where a person is in a wheelchair and that doesn't change. So I think what I would say, and could you ask your question one more time, please?
How should a person deal with that sort of sense of imposter syndrome? How do they develop that disability identity when they're not really viewing themselves as disabled in terms of how the world sees disabled?
So I would say that stigma not only exists within the community at large, but it can exist within the disability community, and it is your right to be able to develop that identity, and it is your right to be able to recognize that. And that if someone has a problem with that, then that's one of those things that's more on them. That's their stigma and that's their bias. You have a right to be able to own your disability, and it doesn't matter if you're passing some of the times and you're not passing some of the time. Does that answer your question?
Yeah, it absolutely does. I think that's an important thing for those of us with that intermittent disability or with chronic illness that leaves us feeling disabled to know, is that our identity is up to us. My second question was if you could speak briefly to the difference between what we're always hearing about as toxic positivity as opposed to positive psychology, just so people don't get the two confused.
Excellent. Yeah. So positive psychology is about realism. And it's about recognizing that, hey, you have these good things, these strengths and these assets that you can draw upon that can help you with your coping. So it's more about focusing on what's going right in your life and how to be able to use those strengths to navigate your coping or your disability. I would say toxic positivity is more of, the differential I would make is it's denial, right? It's almost like you're denying that there's really a problem. Things are going to be okay. Things are always going to get better. It's not very realistic. I think with positive psychology, you can still have a realistic appraisal of what the weaknesses and liabilities that you have are, but recognizing that they don't have to dominate your life.
Thank you very much.
Mm-hmm.
Okay, thank you, Casey. We do have a question, Deborah Foreman. Hey, she'd like to, would you suggest that the patient ask their neurologist or primary care physician for mental health suggestions?
Certainly, yeah, that's an obvious one I kind of missed. I think you can always go back to any of the providers you currently have. More often than not, chances are that they are going to have a close relationship established with some sort of mental health professional. I do some private practice work on the side, and I will say that the majority of our referral, and it's a rehabilitation focused private practice, so we work with people that have had brain injuries, spinal cord injuries, you name it. And most of our referrals actually come from either their neurologists or their primary care physicians. So that's another excellent resource. Thank you.
Okay. We have Elizabeth who has her hand raised. So I'm going to ask her to unmute. Hopefully your hand's not too tired.
Hi. So I also posted this in the chat. I tend to be a very positive person, but with MS and the levels of disability or symptoms always being in flux, I feel like, oh, okay, I've adjusted to this new level and then it changes. Some days it's better, some days it's worse. And I was just wondering if you had any suggestions on how to deal with that.
It's really tough. And I think especially for MS, where you have that constant adjustment and maybe you return back to baseline if it's relapse remitting, or if things have sort of that stepwise progression, it makes things difficult. And research would actually support exactly what you're saying. When people have a chronic disability that's unchanging, their coping or their adaptation is usually quicker than people that might have some sort of disease or illness that causes more of a chaotic pattern of disability. So I would recommend, beyond what we've discussed today, it's difficult to answer that question very quickly. That might be when I recommend seeking either professional help or becoming part of a peer support group or something along those lines. Don't think that you have to do all this in isolation.
Okay, thank you. Thank you for that. And if anyone has, we have very few minutes left, but if anyone has any other questions, feel free to put it in the chat or raise your hand. I do have a question, just as a general. For people, a friend of mine, for example, was in he doesn't have MS, but he was in a situation where he lost many friends at one time, and has been holding on to guilt for about 20 years. And he might see a presentation like this and ask a question of, it's been 20 years, how do I get, and every day I think about the same thing. How do I get out of that loop initially, so I can start growing, so I can start to feel better? Because he wants to feel better. He just doesn't know how or where really to pinpoint where to begin.
One thing I want to say is that when our lives have changed, for better or for worse, we were fundamentally changed as people from that point on. So when major life events happen to us, there's often no sense of like getting over it. We are fundamentally changed. When we lose loved ones, when we suffer some sort of affliction or illness, even positive things like marriage, right? Those are permanent changes in our lives, and we'll never be the same person from that day forward. So I think it's about trying to figure out the meaning or purpose. I think it comes back to that a little bit, and I hate to keep giving this as sort of a one response answer, but don't do those things in isolation. Like, I think seeking professional help is very, very beneficial, because chances are you've exhausted everything that your mind can see right now. And we've all had that moment where we've overanalyzed a problem so much that we've boxed ourselves in, and we just feel hopeless because we can't see any other solutions. And I've had those aha moments a lot working with people, where you offer just a different perspective or a different way of looking things, and they kind of go, huh, I never thought of that before. And so I think relying on others or seeking professional help can be a good way to gain those alternate perspectives.
All right, awesome. Thank you for that. Elizabeth, you have another question. I'm going to ask you to unmute again.
Just quickly, thank you. This was a great presentation. Can we have access to your slides, particularly the 6 value characteristics?
Can that be done?
Yes. So this will be shared on our YouTube channel, which will be available in about a week, as well as our online radio station, and but that won't have the slides for you. So, but our YouTube channel will as well.
Thank you.
So I hope that helps. Yeah. So if there are no other questions, then I'd like to thank you, Dr. Brown, for coming today and doing your presentation. It was absolutely fantastic. And
thank you for having me.
Yeah, and that is all the time we have. If you did miss part of this teleconference, as we just mentioned, it will be replayed on msfocusradio.org and available on demand on our MS Focus SoundCloud page. But if you'd like to see the slides, obviously the YouTube page, and you can find us at Multiple Sclerosis Foundation if you do a search. Please remember to follow us on MS Focus on Facebook, Twitter, and Instagram for times and access information for future teleconferences, as well as when this one will be available. Our next conference will be this coming Tuesday at 3:30 p.m. Eastern with Dr. Ben Thrower speaking with us about health and MS. And our sincere thanks to our sponsors, everyone who attended, and especially to you, Dr. Brown. Thank you so much for taking the time to prepare and share this information with us. Do you have any final thoughts?
I don't think so. I want to thank everybody for having me, and I know this is a unique and individual journey for everyone. And again, if I can be of a help in any way, please reach out to me.
Awesome. Well, thank you everyone for coming, and have a great rest of the day. I appreciate it.